Our next CogWorks theme is the impact of caring and disability on cognitive and mental health. And this is to be presented by Professor Mark Mathews, who is the Chair of Ageing, Health and Disability at the University of Sydney. Professor Mathews is a Fellow of the Gerontology Society of America, and his research has been designed to contribute to understanding of factors that affect successful ageing and application of that knowledge to social programmes that optimise independence and autonomy. Professor Mathews.
Thank you. I'm going to shift gears a little bit and focus on some smaller scale, individualized kinds of programs that my students and I have been involved with over the years. In terms of prevalence of behavior problems within dementia and dementia care, there have been a number of survey sorts of studies that have collected information, and behavior problems are quite common in most dementia care settings. And in fact, over 90% of all residents manifest at least one or more challenging behavior, issue that is a concern or an issue for the residential care staff in nursing homes. And this was from a particular study that was done in Australia, but similar kinds of statistics have come out from programs in other places as well. One of my current students, Jane Turner, has been running a assessment and treatment program specifically for problem behaviors in nursing home settings for the last few years. And in her analysis of referrals that have come into her organization, the two most common issues were the physical and verbal aggression by residents and resistance of residents to receiving care. Now, in terms of residential aggression, resident aggression and resistance to care, typically it's an issue that is directed at those people most immediate environment, sort of within arm's reach, and can often result in injury to carers or to other residents. And it's also been identified as one of the leading causes for staff burnout. Staff, when they have to put up with this day after day after day without any change, once it becomes to appear unrelenting, they're not willing to stay in that setting and continue working there anymore. And one of the other things that we found over time is in any residential care setting where turnover is a problem, again, at least the numbers from the United States, in residential care nationwide, the average turnover rate of nurse aides, who are the direct care providers, the people that have day-to-day contact with residents, is as high as 150% in many facilities. What you end up with in a situation where you've got that high rate of turnover is it's always somebody new coming into the room to provide direct care for a person who's confused. They become agitated because they don't know what's going on. They don't know this new person who's shown up. The new care provider doesn't know the individual's routines and the kinds of things that set this particular person off, which exacerbates the problem. Again, the most common sorts of direct care procedures that these kinds of problems occur in are in bathing, toileting, and dressing. And so I want to give you a couple of examples of some of the kinds of work that we've done to try to deal with these issues. The first study is one that one of my master's students, John Baker, did, where we were looking at the issue of aggression in an older adult with dementia. She was a 96-year-old non-ambulatory woman. She used a wheelchair for her means of movement around the facility. And she had been diagnosed with dementia of the Alzheimer's type. She was referred to us because of aggression against the staff, and she was at risk of being removed from the facility. When we looked into the situation, we discovered that in the previous 2 years she had been in 5 other facilities and asked to leave each of those because of the behavior problems that she was posing, that they couldn't deal with it. She was looking at being moved again. The way that she spent most of her time, she was physically restrained in her bed or her wheelchair throughout much of the day due to her aggression. And she was also on Ativan to try to calm her and reduce the level of aggression against the staff. Now, in the U.S., where this particular study was done, there is federal law that mandates that behavioral interventions be attempted before physical restraints or chemical restraints are prescribed. And that's true across all nursing homes in the United States. That was sort of the context in which we were working. So when we went into the nursing home, they had a formal behavioral plan that they had in place for her. And it involved a hierarchy of 4 steps, where the first thing that staff was to do if she was aggressing against somebody was to calm her with a soothing voice, try to redirect her, get her to sort of focus on something else, provide her with a quiet time with a snack so they'd move her off to the side and give her something that she preferred to eat. And then the 4th step was to administer Ativan as needed. And basically, our experience was they jumped to step 4 quite quickly whenever there was any kind of an issue. When we talked to the staff about what the issues were, when things were the biggest problem for this particular resident, they described it as whenever she needed to be transferred from a wheelchair, either from bed to the wheelchair to the bed, or wheelchair to the toilet. And we did some observations and we watched what was going on, and basically they had a 3-person team dealing with this tiny little woman. And they would have 2 people that were assisting her with the transfer, and another one who was holding on to both of her hands to keep her from hitting people while they were trying to move her from one spot to the next. So in terms of staff time, this was pretty intensive, and it was also one of the nurse aides' least preferred activities to have to engage in during the day. The facility that we were working in was a very nice new modern nursing home. They had a dedicated dementia ward that was fairly small scale. In this particular facility, they had no problems with staff turnover. They had nurse aides working with the residents, many of whom had been there for a substantial long time. And so we were actually working in a very, very good facility as far as the physical environment and the sorts of place that it was. What we decided to look at was, as a dependent variable, was hitting. So whenever our resident made forceful contact with either a closed or open fist against a staff member. So if she took a swing and missed, we didn't even count that. It was only when she was making contact with somebody. And so any attempt that didn't strike a blow was not included in our data collection. We were doing direct observation, so we had somebody on site where we were watching what was going on, and generally our observation sessions lasted between 3 and 5 minutes. And that was because what we were doing is we were focusing on the times at which she was being transferred within the natural course of the day. So we never set up a situation where we asked staff to transfer or move her from one place to another so we could observe. we had an observer who was there throughout the day, and whenever our participant was going to be transferred, that's when he would actually do his data collection. He had divided his data collection sheet into 10-second intervals, and basically any time that our resident hit a staff member or another resident, he'd make a mark that it had occurred in that 10-second time period. And only if no hitting had occurred within an interval was it scored as a non-occurrence. We had our observer sort of follow where the resident was through her day, so observations took place in her bedroom, the bathroom, and the various commons rooms around the nursing home. And the timing that John went to the nursing home to do his observations were immediately after breakfast, immediately before lunch, and immediately after lunch, because those were the times at which transfers were most likely to occur. This is a picture of her room. It was an ensuite sort of setting, so she had her own bathroom that was attached within the room. The first phase of the study, we did an antecedent analysis. So what we were looking at is if there were any triggering events. What was going on within the setting that might be causing this aggression. Again, we did some interviews with staff. They had identified toileting routine as one of the most common situations. And that was also one of the times at which staff were in close proximity to the resident throughout the day. So again, generally, staff were trying to stay as far away from her as possible, or at least beyond arm's reach. So what we decided to do is take a look at looking at aggression during this bathroom routine when she was being toileted, and compared that to observations when a staff member was sitting within arm's reach of her just outside of her bedroom. Picture here is obviously not our 96-year-old woman. The fellow sitting here was the observer who was playing the part of the nurse aide, and Marion Turner, another doctoral student of mine, was playing the part of the nursing home resident. So during the observation sessions, what we did is we set up a scenario in which we could observe what was going on and do measurements every 10 seconds of whether aggression was taking place. Our nurse aide that we worked with as a primary person was a 21-year-old female. She was in the third year at a local nursing program and had been working in this facility, in this particular unit, for 10 months. And prior to our involvement with her, she had no experience in any kind of behavioral assessment or intervention. And at various times, other staff members might have been available or around. Again, one of the settings we were doing our observation in was in the toilet area, and these are some data from this initial antecedent analysis that show that during the bathroom routine, on average, across these 6 observations, about 40% of all of the 10-second intervals, the nurse aide was actually being struck by the resident while she was toileting her. However, if you look at the recreational routine, where the same nurse aide was sitting right beside the same resident outside the bathroom, chatting and just interacting with her, being hit was somewhere around maybe 2% of all the 3% in the control condition. Next, we wanted to do a functional analysis, try to get some better understanding of what was creating this problem, what was causing this problem. So what we did is we taught the nurse aide how to implement 3 different conditions that we could look at to see how each of those related to the problem behavior. The training with the nurse aide took about 30 minutes altogether, and once we finished the training, no feedback was provided during the observation sessions when she was implementing these procedures. One of the procedures we wanted to look at was contingent attention, whether the attention from the staff member was creating this problem of hitting. So what we asked the nurse aide to do during the contingent attention condition was systematically provide verbal reprimands similar to those that she'd been using all along during the observation that we'd done in the antecedent analysis during the bathroom or the toileting, but do it contingent on aggression. So don't say anything to her until she whacks you, and then as soon as she has smacked you, stay in there and let her know that you know this is not an appropriate thing. You really shouldn't be hitting me. I'm here to help you. Again, not step away, and so hang in there and point out why she shouldn't be doing this. We also had a escape condition where what we instructed the nurse aide to do during the toileting session is to say, okay, I'll stop, and then move back for 10 seconds every time that the nurse aide was hit. And because all of our observations were taking place in real life and in real time in the care provision situation, first of all, we set the 10-second limit because that was an issue that the staff were willing to tolerate. And when she was stepping back out of reach, but she was remaining there watching the person to make sure that she didn't tip over, fall, or get injured. So in this scenario, what would happen is provide care, wait till the person whacks, and then immediately after being hit, you step back and wait, pause for 10 seconds before you return to provide your care. The final one was a control condition, which was very similar to what we'd done in the antecedent analysis, where the nurse aide sat in a chair next to a participant and was instructed to provide attention non-contingently, whether she got hit, didn't get hit, just chat with her, don't place any demands on the participant, and don't do anything other than just what you've been doing if you do happen to get hit. So our functional analysis data suggested that when we put that contingent escape condition in, the rate of the problem behavior went up. It was most common during the times when the resident would get a break. When the staff member was stepping away, that's the time at which that was the highest rate of hitting. Again, the control condition was the lowest rate, and the attention condition was somewhere between the two, about 18%. As far as treatment, because what we found was that the highest rate of hitting was during the contingent escape condition, we designed an intervention to provide a time-based delivery of the reinforcer that we believe was maintaining the participant's aggression. So what we did is we went back and we looked at the data sheets that were scored of hits every 10 seconds and determined that the average latency, the time between the start of the session and the first time that the nurse aide was hit, on average was about 33 seconds. And the average interresponse time between the first hit and the second hit, or the second hit and the third hit, was about 27 seconds. So that was sort of the time pattern that we discovered. So what we did is we set up our procedure as far as treatment based on those sets of expectations and assumptions. So by calculating the shorter of those two times, we came up with a time frame of 20 seconds. So the length of time for the reinforcer, or stepping back, we established it at 10 seconds, which was the same as we'd been using during the contingent escape condition. And then the aid was to stay in and continue providing assistance for 20 seconds. So we looked at 20 seconds as sort of a safe period that she wasn't likely to get hit, then to step back for 10 seconds to give her a break, and then come back in for another 20 seconds for providing assistance until the procedure was finished as far as doing the toileting. We used some really high-tech equipment here. We went to a Walmart and bought a Timex Expedition model watch. It cost us $6.35 at Walmart in Lawrence, Kansas. And with it, we were able to set it for a timer for 20 seconds, an alarm would beep for 10 seconds, and then you could hit reset and it would do the same thing again. So we bought this watch, we programmed it, we provided it to the nurse aide, and taught her how to use it during this procedure. And what we found when we put the treatment plan into place, this non-contingent escape condition, first one with open triangles here, we were able to reduce the rate of hitting down, and over time it started going down. So from session 28, 29, 30, and then it started dropping off lower and lower and lower. Now, one of the things that we found really interesting is in talking to the nurse aide, we saw these data as being very convincing that the procedure was really working quite well. We talked to her, and she didn't think that what she was doing had anything at all to do with it. She just thought that the resident was having a good day today and had been having a bad day previously. So what we did is we conducted a reversal. So after 8 or 9 sessions of using the non-contingent escape procedure, we asked her to use the contingent escape procedure that we'd used in the functional analysis. So continue providing care until she hits you, and as soon as she hits you, then step back for 10 seconds. And then wait your 10 seconds and then move back in, and as soon as she hits you again, then move back for your 10 seconds again. And as you can see, the rate of hitting escalated immediately during that first session that the contingent escape was in place. Now, one of the other things that I didn't describe to you on this graph is the little ellipses at the beginning. Those were days on which she was given Ativan as a regular part of her treatment. And that continued up through day 20, which was sort of the middle of our assessment procedure. And at that point, independently, the medical staff decided that she was doing better and she didn't need to be on Ativan anymore. So they took her off the regular prescription of Ativan that she'd been getting on a daily basis. Well, after our first observation session in the contingent escape condition, the nurse aide was so freaked out by this, the medical staff gave her quadruple amount of Ativan from what she'd been getting on the daily basis previously. So our second observation that took place was after she'd been hit with this large amount of Ativan, and she didn't hit the nurse aide at all, but she also was barely conscious and barely able to do anything. The next day, we went back. We used the contingent escape procedure again, both before lunch and after lunch. We asked the nursing staff not to administer Ativan so we could sort of see what was happening without getting her really doped up. And what we saw were very high rates of hitting taking place again. We asked the nurse aide to go ahead and switch back over to the non-contingent escape procedure, which at that point she was really glad to do. And we saw the rate of hitting decrease back down to the level that it had been before. And after about 5 or 6 more sessions her rate of hitting got down to a near zero level, and our nurse aide was absolutely convinced by then that it was what she was doing that was really making the difference, and was willing to talk with other staff and suggest that this is something you really want to do with her as well. So again, a very, very simple sort of behavioral procedure was found to be quite effective in reducing this behavior problem. It was something that could be administered by the nurse aide, who was the person who'd been working with her all along, and it was quite clearly superior to the effects of the pharmaceutical chemical restraint that had been provided previously. And what we found was that following this program that we did, the nursing home was actually quite pleased to have her remain in the facility, and they stopped using the physical restraints on her altogether following the study. Second quick example of another kind of approach that we've had with a similar kind of issue is that of dressing. And again, many people with dementia, when they go into care, they're often able to do many things for themselves when they first go in, but shortly after they've been there, their self-care skills start to decline pretty rapidly. In this particular study, we were working with two nurse aides. Both were white females with some college education, 35 and 22 years of age, and they'd been in this unit for one of them 13 months and the other for 33 months. So they'd been around, they knew these residents well, they'd been working with them for quite some time. In this particular study, we were working with 3 older adults with dementia, aged between 79 and 87. Each of them had a fairly substantial level of cognitive impairment. Again, this was a dementia unit that was specifically designed for caring for people with dementia, and the nurse aides each worked an 8-hour shift. So what we did in this particular one was we were looking at the level of assistance that the nurse aide was providing assistance in helping each of these 3 residents get dressed. So what we did is we came up with a checklist that involved sort of each of the phases of a person getting dressed, and we had the observer score sort of that level of assistance that was necessary or was applied. We did, again, an in-service training for our nurse aides one at a time in using what we call the system of least prompts, and we gave them an opportunity to role play this with us first and then do one dressing session with a person where we provided feedback, and then they were on their own, so we didn't provide any further feedback beyond that. So what we would do is ask them to prepare the area, that for each of the steps in dressing that they'd provide at least 2 less intrusive prompts, either a verbal description of what to do or gestures, before using some physical guidance where the person would assist in it, and then the highest level of assistance would be where they actually did it for the person. Here are data for it, and I'll just go over this real quickly. The open circles and open triangles are days in which the dressing assistance was done before the training and using the system of least prompts. Circles were for one of the nurse aides, the triangles were for the other nurse aide, and so they worked on different days from one another. The closed circles and closed triangles are the days in which the same care was being provided by the same person, but it was after the training. And as you'll notice, systematically, for the first person, as soon as the training was provided, she was dressing herself totally independently. So it was really a very simple sort of procedure for her to get her to start dressing herself again, where she hadn't been doing any of it herself before. For the other two folks, we had a bit more of a mixed process, but in both of those people we got increases in their level of capacity. And again, one of the things that we found in this particular study was over time, one of the steps in the procedure was to praise a person for each thing that they did independently. What we found in our observations was the praise was something that wasn't being used consistently, particularly as time went by. And we actually ended up doing a replication of this where we focused on ways to increase the probability that the staff would provide praise for performance, and got much better level of compliance, of ability for folks to dress themselves from that. So, thank you. My time's up now. Again, I'll be around for the day, and we'd be delighted to talk with folks about any of the work that we've been doing.